So I was asked to speak on the topic that I present frequently about iodine. And there's several other topics that I talk on quite frequently that many of you may know. But this is one that I do a lot for the medical associations, whether it be AAEM or ACAM, about iodine and the underutilized element that this is in our health. Now, iodine deficiency disorders are really quite pervasive, and it can occur in any sort of age group, from fetal deficiencies, neonatal, child and adolescent, and adults. And we're going to spend quite a bit of time talking about this issue, that iodine deficiency related to hypothyroidism and hyperthyroidism, and how we may have missed some very important things in terms of treating our patients. Therefore, iodine deficiency diseases is the leading cause of preventable mental retardation in the world. And that despite nearly 100 years of iodinized salt, iodine deficiency still exists in the U.S. So why is iodine deficiency increasing? If we have iodinized salt, where else do we get iodine that we may not be consuming it anymore and may be contributing to the deficiency? That the Japanese, the Taiwanese, and some of the Chinese having the lowest levels of breast cancer in the world, I personally don't think that that has a lot to do with the amount of soy that they take in, which is what we've been told. I really think it has a lot to do with how much iodine they take in, because they have a large appetite and diet with a lot of sea vegetables and sea animals. They're living on an island, particularly in Japan, where the salt from the ocean, particularly the iodine, because it's actually a gas, falls onto their soils. They have higher concentrations of iodine in their soil. And so the women there have a much higher level of iodine endemically, and that's actually been shown in some of the research studies. And that when those women in Japan move to the United States, and we see that their increase of breast cancer goes up, I think that a lot of that has to do with what we're talking about here, that their iodine consumption goes way down. So how much iodine do we really need? Iodine deficiency as a risk factor for goiter has been known since at least 1820. And in 1916, Dr. David Marine conducted trials in Akron, Ohio. He looked at two groups, and I believe there were somewhere between 800 and 1,200 girls in each one of the groups. And in one group, they were treated with potassium iodide. The other group was non-treated, and they followed them for several years. In the treated group that had the potassium iodine, only 2 of those girls had developed goiters, and in the control group, 250 had developed goiters. So from that study, back in 1916, they decided that the best way to get iodine into the diet was through iodinized salt. And in 1924, iodinized salt began to be used in the U.S., and it was first used in Michigan. The iodine is important for many other tissues in the body that I'll show you in a minute. There's never really been any studies that have been done to develop and determine what the total RDA requirement is for the body. So how does iodine get into the tissues? I mean, is it just a passive diffusion? I mean, how do we get it in there? Well, on the surface of the thyroid, there is this glycoprotein called the sodium iodine symporter, or NIS for short. And what that does is it imports the iodine that's in the circulation, or something that we've eaten, into the thyroid, and then makes our thyroid hormone from there. Interestingly enough, the NIS, or the symporter, has been found on many different tissues in the body, disproving the previously held view that it is a thyroid-specific protein. And it's what the NIS does is pumps the iodine into the other cells of the body. So for the rest of the body, the NIS, or the symporter, mediates active iodine transport into the following tissues: pancreas, liver, and the mucosa of gastric lining, the small intestine and the large intestine, the nasopharynx, lacrimal glands, choroid plexus, the ciliary body for dry eyes, skin, mammary glands, and salivary glands. So these are some of the other organs in the body that are required to have iodine, but we don't even know how much, because all we know is the 150 micrograms for the thyroid. And that when the symporter, the activity of the symporter on the surface of the cells of the thyroid is increased in the presence of TSH, or thyroid stimulating hormone, and that is when the TSH goes up, that is pumping iodine into the cells, which is not quite the physiology that we were taught, and I'm going to talk about that a little bit more in a minute. But this is kind of what the surface of a thyroid cell looks like. And that TSH, for thyroid stimulating hormone, goes and stimulates that symporter to drive iodine into the cell. And as it puts the iodine in, it pumps the sodium out. And what people may not realize, I tell my patients all the time, is what T4 is. When you order a thyroid test and you order T4, what that is tyrosine, the amino acid tyrosine, plus 4 molecules of iodine. That's what our thyroid hormone is mostly made out of. So TSH, it starts the process and puts the iodine into the cell. It couples up with tyrosine here, and then it also affects the thyroid peroxidase iodinization here and here and here. So you get tyrosine plus iodine, and then you get the monoiodinized, so there's one iodine plus one tyrosine adds another iodine, and then 2 of those go together and we end up with T4 down here. So that's normally what happens. And so, so if you start adding iodine in, the TSH goes up a little bit in response to that because the TSH is, or because of the presence of the iodine, because the TSH is driving it into the cells. When you are iodine depleted, and I mean very depleted, very long-standing, that this happens over a long period of time, what ends up happening is that selectively this process goes up to T3, because T4 is the inactive form of the hormone that floats around out in the bloodstream. It goes into the cell, and at that point, one of those iodines is snipped off by a selenium-dependent enzyme we're going to talk about in a minute. And the active form of the thyroid hormone is T3. T3 is preferentially made in the presence of low iodine because that's the one that your cells need. And so it saves that step. And so when you see this sort of process happening, think low iodine. And when you think about it, we're going to talk a little bit more about hyperthyroidism in just a minute. When you think about it, when you see patients that have had hyperthyroidism, which is very low TSH because they try to shut off this process, but you've already preferentially activated that pathway, and you have low TSH, high T3, what is the conventional treatment for that? They give radioactive iodine to kill the thyroid. Maybe what we should give is just like non-radioactive iodine and like heal the thyroid. When you get a thyroid blood test, frequently you get TSH, free T4, free T3, total T4, total T3, and we always order anti-thyroid peroxidase antibodies. We always order TPO antibodies because thyroid peroxidase antibodies, the presence of those tells you that you've got Hashimoto's disease. And Hashimoto's disease is frequently, sometimes they're low thyroid, high thyroid, low thyroid, high thyroid, and it can be a little bit hard to regulate that. So those are the battery of tests that we usually get. I've started thinking of selenium and iodine as sister molecules. I don't give one without the other. I really think that they're really, really important for a lot of reasons. Selenium deficiency may have a profound effect on thyroid hormone metabolism and possibly on the thyroid gland itself. There is a selenium-dependent enzyme called type 1 deiodinase. It's a selenium-dependent enzyme that plays a major role in converting that T4 to T3 in the periphery. So TSH goes down and stimulates your thyroid hormone, or your thyroid, to make T4. T4 floats around out there in the bloodstream and it ends up going into the cells. It's activated at that level by a selenium-dependent enzyme, and it's the T3 that is what drives your engine. So without the selenium, that doesn't happen very well. And if you're adding selenium only in and you're not aware of whether or not the patient is iodine deficient, these are some things that can happen. That enzyme increases in the cells and starts transporting more T3 into the cell, which drops T4 in the bloodstream, which conventional doctors, or those that aren't aware of this, will start thinking that the selenium is making that person be more hypothyroid. And it's really not. It's just a physiological response. If the patient, in addition to being selenium depleted, and you're putting the selenium in, if they're also iodine depleted, there won't be any iodine to go through that process with the symporter to replace the T4. So the T4 drops, and everybody thinks the patient is becoming hypothyroid, and they're really just selenium and iodine deficient. The TSH will go up because it's trying to capture whatever iodine happens to be floating around out there. So we'll see this combination of low T4 and elevated TSH, which by definition we often think of that as hypothyroidism. But if you take a step back from that, really what they are is selenium and iodine deficient in the large percentage of the patients. So when you see these two things together, and this came from the Journal of Endocrinology in 1997, so this information's been around for a while, that prolonged selenium deficiency coupled with iodine deficiency may lead to tissue hypothyroidism and impaired brain function. That's really important stuff. One of the things that selenium does is the selenium deficiency lowers the concentration of glutathione peroxidase in the thyroid. You need the selenium there for the glutathione peroxidase. Glutathione peroxidase detoxifies the thyroid gland. In the process of all those steps of making thyroid hormone, one of the byproducts of that is hydrogen peroxide. That's just as one of the byproducts of it. What selenium does, it acts like a little sponge and takes away that hydrogen peroxide. So when a person is also iodine deficient, and that accumulation of hydrogen peroxide without the selenium, it causes the thyroid cells to die, and you subsequently get low thyroid or hypothyroidism. The other thing that you get is that Hashimoto's, that back and forth, sometimes high, sometimes low, sometimes high, sometimes low. And you hear patients who have all the sluggish sort of stuff of hypothyroidism, which is cold hands, cold feet, dry skin, hair falling out, cold, constipation, inability to lose weight. They switch from that to the, I'm feeling really anxious and really hyper, and I can't sleep at night, and you know, I'm just really feeling anxious. That swinging back and forth is very indicative of Hashimoto's. So here's a real pearl to kind of think about, that even mild selenium deficiency can contribute to the development of autoimmune thyroid diseases. And if you do have a patient that has Hashimoto's, there's a whole lot of other things to think about, including mercury toxicity to the thyroid. That's one of the things that can happen. You've got this mercury stuff here that just sort of falls down into the thyroid through your lymphatics. So you can have a mercury issue in the thyroid, you can have a low selenium level with the thyroid, and you can have a low iodine level with the thyroid. All those things kind of all couple together. There have been many reports in the conventional literature that says that just by adding selenium, that 40% of patients with Hashimoto's disease will recover. Their antibodies will go away and they will recover just from selenium. So we've talked about a lot of the things that the selenium does. In our practice, we really think there's a difference between normal, optimal, and a really perfect range to say that everything is in balance between the iodine and the selenium and the different hormones in your body. And we like to see the TSH somewhere between 0.1 and 1.5. If we have a mildly elevated TSH, when I mean like about a 2.5 or a 3, 3.5, that would still be in the normal range, but is getting to the upper end of the optimal range. But you've got a normal T4 and a normal T3. What I think about that is that this is really an iodine deficiency issue, because T3, and particularly if those patients are complaining about depression and fatigue, and they can't lose weight, and they can't think clearly, and they've got all this brain fog sort of stuff, what I think is this is really an iodine problem. The TSH is going up because it's trying to capture all the iodine that's floating around up there as best as it can, and it's trying to put it into the tissues, particularly for the thyroid. So I'll start researching and I'll start looking, and we'll start doing some testing, which we'll talk about in a few minutes, to look for low iodine. T3 is not, the T3 that's in the periphery, it does not like cross the blood-brain barrier and go in and provide the brain with thyroid hormone. It's made locally in the tissue of the brain itself. So it's not derived from circulating T3, so that tells me there's really an iodine deficiency going on in the brain area. Now, if they have a high TSH and a low T4 and a variable T3, I mean, by definition, that is, we call that what? Hypothyroidism, right? T4 has gone down, TSH has gone up, maybe the TSH is 8, 9, 10, it's really, really high. So we say, wow, this person doesn't have enough thyroid. Well, I say what they really need is more substrate. They need more iodine to be able to make the thyroid hormone. They may need more tyrosine on board to have that. They may need a little bit more selenium. And then the opposite one of that, of a really low TSH and a really high T3, whenever we see that, it's like, wow, this is hyperthyroidism. We have to do something and stop that like right away. You don't want that to go on for long term. I mean, long term meaning 6 months, a year, something like that, untreated. Because when it really goes up, then you've got the cardiovascular symptoms you have to worry about. You have to worry about osteoporosis, a lot of different things with long-term hyperthyroidism. But because what the body's trying to do is to say, I'm so iodine deficient that I'm going to bystep that T4 step and go right to T3 because that's the active form. And it's the protective mechanism in the body. What we do with that is we test them to see where their selenium levels are and start putting in some selenium to stabilize the tissues, and then ever so slowly start adding iodine back in. And all of that treatment for hyperthyroidism, that's the way they did it back in the 40s. It's all in the medical literature. This is nothing new. It's been around for a long time. It's just that we don't really go in that direction very often. So that you start with a very low dose of iodine to start to regulate the system. The magnesium is really important to stabilize the thyroid, and zinc really helps to stabilize it too. We have, between me and one of the other doctors in my office, Dr. Cheryl, she and I treat most of the adults. She treats about 80% of her practice is kids, and all the kids on the autism spectrum disorder go to her. I see most of the adults, but between the two of us, we have a case, we're putting together a case report now that we've got 10 patients now with frank, overt hyperthyroidism by every definition of the book. And that over a 3 to 4 month period of time, we've been able to completely reverse that by making changes in their diet, getting rid of all the stuff like aspartame and all the stuff they shouldn't be doing anyways, taking out white sugar, white flour, and all those acidic sort of molecules, and starting to slowly add back in selenium and iodine. We've got 10 cases now we've completely reversed. So we're keeping a little, at some point we're going to write a whole case report, maybe put it in the Townsend letter somewhere to get the information out to everybody. So I just want to show you that from our own clinical experience, we've been able to do this and make this work. Okay, the Pearl is treating Hashimoto's with selenium, 200 micrograms twice a day to remove the peroxide that's accumulating in there, in the gland, that is possibly contributing to their Hashimoto's. And once that starts, and I would do that for probably a month or two, and once they start to improve from a clinical standpoint, start to add in just a little bit of iodine at a time. Clinic Pearl number 2 is whenever you see an elevated TSH, think iodine deficiency first. Don't think they need more thyroid hormone, or they need more Synthroid or Armour or Thyrolar or whatever your medication of choice is. Look to see if there's an underlying cause for this. And then if a patient is treated with selenium and their symptoms and their lab tests get worse, if you're using selenium in a multivitamin or for whatever reason that you're using it, it's probably because they're iodine deficient, like we talked about. So what's the relationship between low iodine and breast pathology? Can the tissues start to lose their substrates to keep them healthy? They start to degrade and break down. The body has the ability to heal and repair itself when you put the missing biochemistry, put the biochemistry back in. In 1976, epidemiological data suggests that the relationship between regions of known endemic goiter, known to be related to low iodine, increased breast disease, and that was in the Lancet in 1967 and Cancer Causes Control in 2000. There was studies that were in 95, 96, and 97 that showed the histological changes can be reversed in the breast tissue with introduction of iodine. Rat studies demonstrated that iodine suppresses the formation of breast tumors. And then this one is really important, that iodine absorption and organification occurs in the same ductal epithelium where the majority of breast cancers occur. So how much iodine is needed to have healthy breasts? We keep talking about 150 micrograms for a healthy thyroid. What about healthy breasts? Well, breast tissue is actually like a sponge for iodine, and studies have shown that a minimum amount of iodine to protect the breast from fibrocystic disease and cancer is 20 to 40 times more than needed to prevent a goiter. In other words, the breast needs instead of 150 micrograms, it needs somewhere between 3,000 and 4,000 micrograms a day for healthy breasts. That came from an article from 1993. So again, this is information that's been around for a while. Iodine in diseased breast tissue, the incidence of fibrocystic changes among women is reported now to be more than 60% of women have fibrocystic disease in their breasts. About 5% of those are considered to be risk factors for developing breast cancer, and that these changes respond and reverse in the presence of 3 to 6 milligrams or 3,000 to 6,000 micrograms a day taken for 3 to 4 months. It's like, wow, in 3 to 4 months we can reverse all that and reverse all those things that I just showed you? That is astonishing. People need to know about this. So what about iodine in the salivary glands? Well, we found that there's a symporter on the thyroid. It's also been found in salivary glands. Iodine concentration in salivary glands can reach 30 to 40 times that's seen in plasma. Fluoride and bromide inhibit transport of the iodine into the saliva, and thiocyanate inhibits iodine transport and utilization in the salivary glands. Thiocyanate, most commonly in most of the patients you're going to see, probably it's mostly going to come from cigarette smoke. It's also found to be a little bit in these foods, cabbage, broccoli, almond, horseradish, and corn, but the food contributors have found to be inconsequential. So that's really not a big deal. Is that first thing in the morning, you put that drop of iodine right here on your wrist on a non-haired, thin-skinned area and sort of rub it together. Do it over your bathroom sink because you don't want to stain it on anything because it is iodine. When you rub it together, it takes maybe 10 seconds for it to dry. And once it's dry, you really can't rub it off. I mean, if you really tried really hard to rub it off, you really can't. And so I have them do it here on their wrist so they can watch it. And when they first put it on there, it's that iodine, very dark yellow gold color of what iodine is. And it should stay that dark for at least 12 hours, preferably 18 hours. We'll have patients take it home, and if they put that drop on there, and it's the next time they look at it, it's like 3 hours later, and they see no trace at all of any color left there at all, then I go on the assumption of saying, well, maybe we better look a little bit closer, a little bit farther to see what your iodine deficiency is. So how much iodine is safe, and how do you kind of put this back into people's systems? So I look at iodine treatment, it's kind of like a drug. I mean, you have to individualize it to the patient. You have to watch for side effects. There are things that you have to do. It's not just like taking, say vitamin C over the counter or vitamin E or something like that, that you've got a lot of flexibility, or vitamin D, you've got a lot of flexibility. There are some things that may come up that you have to be aware of. So are there some potentials for some side effects? And I say yes, and I've seen them. And you just have to sort of deal with them. One of the things is something called iodinism. I mean, this is what people say that, I'm allergic to iodine, I can't take it. Well, it's a mildly toxic syndrome resulting from the use of iodine. This is what is, by definition, what iodine allergy is called. I have sort of an issue with it I'll talk about in a minute. That's a mildly toxic syndrome from the reuse of iodine. I don't think it's the iodine, and I'll explain that to you in just a second. It's defined in the textbook as rashes, acne, stomatitis, unpleasant metallic taste in the mouth, gastritis, nausea, headache, a lot of salivation, fatigue, coryza, runny nose, sneezing, conjunctivitis, laryngitis, bronchitis. That's in the textbook what they call iodinism. They say that if you have any of those things, you're allergic to iodine and you can't take it. Well, I came up with something a little bit different after looking at a little bit more research. And if iodine is important to every cell of the body, and particularly for your breasts and your thyroid, how can it be that you can't take that? Well, so I came up with this kind of a working theory. And this is because I did a lot more research into that whole toxicity list that is on there, and that iodinism may really be a cellular displacement of bromine, fluorine, and chlorine while you're replenishing the iodine. If you have missing iodine, you're more likely to absorb those smaller molecules. Well, look at this. Bromine toxicity. Look at the symptoms that bromine toxicity is. Skin rashes, acne, loss, metallic taste in the mouth. Wasn't that one of the things they talked about iodinism? Well, if you're displacing bromine by putting more iodine in and you're releasing the bromine, aren't those some of the symptoms that you're going to get? And I put a list, I won't read all this to you, it's in your handout. All of these asthma medications have bromine in it, and bakery products have bromine because they decided that, remember when we were kids growing up, they used to talk about Wonder Bread and had all those minerals in it and had iodine in it. Well, they took the iodine out and replaced it with bromine. So now in a lot of those substances, and a lot of these, you get brominated vegetable oils, and they're in all of these soft drinks, and all the bakery products have bromine. So we're getting more and more and more and more bromine all the time. When you start bringing the iodine up, the bromine has to go away. And I think that a lot of the bromine releasing the toxicity of bromine from the body is being blamed on an iodine allergy, which really isn't there. Fluorine toxicity, the same thing. It goes along with those symptoms. Skin rashes, headaches, stomatitis from fluoride. Those are the medications and things that have been removed from the market, or actually are still out there because they have fluorine in them. And chlorine toxicity causes that sinus inflammation and sneezing and taste disturbances, and that comes from Splenda and public drinking water and hot tubs and propellant spray cans and swimming pools. So as we get low iodine and we get more absorption of bromine, fluorine, and chlorine, as we start bringing the iodine up, this stuff has to come out. So the key to that is add the iodine in very slowly. Before we start adding any iodine in at all, we want to do something with selenium. We really want to make sure that the body is pretty saturated with the selenium. So we'll look for the selenium deficiency either on a regular blood test, or we'll look at it from like the SpectraCell test I talked about that we used a lot. And we tried to keep the total amount of iodine that people use at less than about 3,000 micrograms or 3 milligrams a day for a while. You know, you can go up from there, and I think that that's safe to go up from there as patients need it, but I think initially you're going to end up with more side effects if you go above that dose. So be sure that the patient is loaded with selenium for at least 6 to 8 weeks before starting the iodine. We always also have them take tyrosine, because tyrosine and iodine together is what makes your thyroid hormone, and we add a little magnesium. Because that facilitates the binding there. The tyrosine, usually 500 milligrams twice a day, is what we recommend. And we start with the selenium, 200 micrograms twice a day. And we'll do that for about 6 to 8 weeks before we start adding in the iodine on just normal routine paces. So I think that the more deficient you are, suddenly you start putting in a bunch of iodine, the TSH is going to go way up, and you're going to start running the iodine into the tissues through that symporter and kicking out the bromine, fluorine, and chlorine at a really high rate. And I don't think that you need to do that. I think that you can do it really slowly. Thank you.